Gives me great pleasure to invite and introduce a good friend of mine, Dr. Pradeep Bhandari from Portsmouth, UK. And Pradeep is going to give us his opinion about the role of premedication for to get an ideal imaging during endoscopy, and he's going to talk to us about the BSG guidelines. So over to you, Pradeep, and then we'll have more questions, I'm sure.
Excellent. Thank you very much, Amol, and thanks to the organizer for organizing this meeting, because I think this is a very important topic and a very important meeting, because most of the conferences and meetings don't address this part of the endoscopy because they consider this is not sexy enough, and people will not come to attend. So I'm pleased that we have delegates who are interested, and I'm pleased that the organizers have put up a topic which is not very sexy, but I think it is an essential part of our endoscopy going forward. So I think Noria has covered almost everything you need to know on this topic. So I'll try to just give a slightly Western perspective to it, but won't take too much time. I want to make sure this term mucosal toileting becomes popular and people start using this term, because this is what we exactly are doing for upper GI. Is we need to, like the bowel prep, we need to start doing upper GI mucosal toileting to improve the quality of mucosa. And this is the reason why we need to do that. This is the meta-analysis which shows that 11% of upper GI cancers are being missed. So 1 in 400 gastroscopy that we all do, we're missing a cancer. It might vary from unit to unit, it might vary from person to person, but overall, most big centers will have a miss rate, and we can minimize that. And one of the ways of doing that will be by improving the mucosal visibility. I feel these are all the essential steps for improving early cancer detection. And you can see experience plays a very big role, but experience without understanding the basics and without getting the basic knowledge is not very good. So you have to follow this algorithm and go up the pyramid in a systematic way rather than go straight with the technology. So you might be working in a very rich center where you can afford to buy the latest technology and latest endoscope, but if you haven't gone through this pyramid, you are not going to be very successful, I'm afraid to say. So please pay attention to that. And again, a passion is something else. Some people just have the passion to pursue and perform the best quality endoscopy, and some don't. And again, if that is missing, your detection rate will still be lower despite all the things that you've done. I won't spend too much time on this, but I find that people should pay attention to this algorithm. Bowel cleansing is now very well accepted throughout the majority of the countries. Majority of the national societies promote adequate bowel cleansing, and there are very good data to say that if you have inadequate bowel cleansing, we should repeat colonoscopy. BSG recommends that, ESG recommends that, ASG recommends that. Everybody does that, but there's nothing like that for upper GI endoscopy. Nobody recommends to look for that mucosal visibility and recommend a repeat gastroscopy because mucosal visibility was not good. But this is something we need to push to improve the quality of gastroscopy. Without paying attention to mucosal preparations, all these technologies, all your skills and your expertise will be wasted. And I'm afraid to say, this is the type of stomach it's not uncommon to see outside of Japan. You don't see this in Japan, but outside of Japan, it's not uncommon. Most centers, most units, we all see this on a routine basis. And this should become unacceptable. We should not accept this kind of stomach anymore. This is what we need to see. This is from Japan. This is not a Western stomach, but we can always produce exactly similar quality if we pay attention to mucosal preparation. So I was in Japan at National Cancer Center in 2006. When I came back to England after 6 months, I wanted to introduce Pronase and Gascon in our unit. And I immediately faced a lot of resistance about risk of aspiration. Standard guidelines is 4 hours of fasting. How can you give a drink? People will aspirate. The next challenge was the data is not good enough. So while I was in Japan at National Cancer Center, I did this randomized trial at the cancer center, but never got to analyze the result, never published. It took me 4 years after I finished in Japan to publish this trial, which showed clearly that if you have a drink of Gascon and Pronase, then it is far superior than the flushes of Gascon alone or of the two combined together. So drink is better than the flushes, and that was the conclusion of our study. And it also showed that there was no risk of aspiration. Because I have to say that when I went to Japan in 2006 and I saw everybody drinking this just before gastroscopy, I was very nervous about aspiration myself, because this is the culture I went from. And this study clearly shows there is no reason to worry about that. However, we were not allowed to use Pronase. Pronase outside of Japan is considered as a non-medicinal product. We don't get a medical grade Pronase. It's a non-medical grade Pronase, so we cannot use it. So that was my next barrier. We could not introduce, so we were just using simethicone till we discovered this N-acetylcysteine. So we had to repeat a randomized trial because the other barrier was all the data was coming from the East. There was no Western data. So I had to produce a Western trial using Western solution, which was N-acetylcysteine and simethicone. And in this randomized trial, I can tell you that it was a lot better. When I was in Japan, I suggested to Dr. Gatoda that our control arm should be with no drink, no flushes. And he said that's ethically not acceptable in Japan because our standard is a drink. It's against our ethics. And I said, well, the rest of the world doesn't give any drink, Dr. Gatoda, we can use it. So no, this is not acceptable ethically, we're not going to. So in Japan, I could not use no drink arm because ethically they said it was not acceptable. So I thought in the UK, this is a conventional practice. So our group C was no drink. This is what most of the world does. Then group B was a drink of 50 ml of water. And then group A was our experimental arm with N-acetylcysteine and simethicone. And we clearly showed that if you have the drink with N-acetylcysteine and simethicone, then you have better mucosal visualization than any of the other two arms. One other thing was that when we were doing the BSG Barrett's guidelines, and quality standards guidelines, I wanted to push for a drink before gastroscopy, and everybody said there's no data outside of stomach. It only improves visibility in the stomach. All the trials say it's only for stomach. So we specifically included all the mucosal visibility stations in fundus, antrum, upper body, and lower esophagus. So our study shows that it improves mucosal visibility even for esophagus, not just for stomach. So it is recommended for our Barrett surveillance that we use it because it improves the visibility for Barrett's. And that's what was incorporated in these 38 statements that we produced for improving the quality standards of gastroscopy. I would strongly recommend everybody reads that because they are very practical statements. And 2 of them are about adequate mucosal visualization, which can be improved by using a mucosal cleansing technique. Now, they didn't want to go down recommending a drink alone, but that's what I feel is better than just using the flushes. And we also recommend quite strongly that the quality of mucosal visualization should be reported in your gastroscopy. because this leads on to then recommending, if the quality is poor, what you should be doing. So this is what we say, the mucosal visualization should be reported in all your studies, because if it is poor, then I feel that a repeat examination should be suggested. And we do recommend use of the technique. As I said, I believe that the drink is better. It's well proven in all the studies. That's what you should be going for, is a drink before endoscopy rather than using it as a flush. And then you can have stomach looking like this, and then you will not miss this early gastric cancer seen at 7 o'clock. If we use any of these, whichever one is available in your department, in your country. And I agree with Professor Oedo completely that we should do a systematic examination. We don't, we couldn't recommend so many pictures as Japanese colleagues recommend, but we do recommend at least 8 pictures on all these 8 stations. And I feel if we start taking pictures, when you look at these pictures yourself, you will see, oh my God, the preparation is not good. So it will make people think back saying, oh, this doesn't look good. There's so much mucus. We need to do something about it. So I think pictures will still push people to change their practice. And I know this is not part of this meeting, but I think safe sedation is really important. If patients are not sedated, I find a big difference in our Japanese patients versus the Eastern and the Western patient. Japanese patients really tolerate the procedure very well, whereas the patients in the West don't tolerate it very well. They need to be sedated adequately based on the age and comorbidities. And we want to promote safe sedation, so it's mandatory in our unit. If we cross the safe sedation guideline, we need to report that and investigate that. We report all our sedation related complication. If we ever use a reversal agent after endoscopy, that gets reported and that gets investigated. And that just improves the practice of sedation overall. So in order to move on quickly, this was another dilemma, whether sedation can be mixed with throat spray or not. A big BSG guideline audit a long time ago showed that if you combine, it increases the risk of aspiration. But recent data suggests that it doesn't, so looks like it's safe to combine the two. I won't go into these details because without, I think Professor Uedo has highlighted it enough. If the stomach looks good, only then you'll be able to use these dyes and make these diagnoses. So I won't take much of time. And same applies for all these technologies. They will not work unless the stomach is clean. Look at this. This esophagus is really clean. Only if you have esophagus looking so clean, you will spot a subtle early squamous cell cancer. This is an early squamous cell cancer. If you have bubbles, you will miss this. There's no chance of mucus and bubbles being present and you finding this. This is the reason why we miss a lot of squamous cell cancers, because in the early stage, they are very subtle. If you didn't believe me, when I showed you that red patch, here is the evidence after Lugol. You can see this is a early squamous cell cancer. You'll only find it if the stomach, if the esophagus and stomach are clean. Same applies for Barrett's. You can see this is a very early mucosal change. You can use all the technologies with TXI, making it more clear. When you use NBI, you can see the 2C depressed area. The vessel pattern there is lost. That is showing evidence of more than mucosal pathology. We can only use this technology and say that because it's so clean. Barrett's has the advantage if you use acetic acid. Acetic acid is a mucolytic agent. So I find that when I use acetic acid, it takes care of the mucus as well as it highlights the neoplasia. You can see there's immediate loss of acetowhitening. That's the focus of cancer. But all this area around that is lost as acetowhitening. You see that? It took some time, but it lost its whitening. and you only appreciate because it's so clean, and that's an area of high grade. So that's a cancer which immediately lost the whitening. This is high grade, which took a little while. And this is what we promote for people to look for the differential loss in timing of acetowidening, and that gives you a histological diagnosis if you time it. I'll stop there and be happy to take some questions. I'll stop sharing the screen so that we can talk. Thanks a lot.
Thank you, Pradeep, for a wonderful talk and overview about what are the practices in UK as well as in the West. I think you represent majority of the Western endoscopists who are into early diagnosis and treatment of upper and lower GI cancers. Now, couple of things which I had, which I wanted to ask you about. Yes, as you rightly mentioned, mucosal toileting is not a very commonplace occurrence outside of Japan, and we too see this in India very often that patients are not well prepared. Patients want to rush into an endoscopy, even physicians want to rush into an endoscopy, and often an incomplete examination is performed, or even in presence of stomach, food in the stomach, sometimes a report is given. So this question is a little bit more of a philosophical question as to how to get these guidelines implemented into clinical practice. Probably the question is for both for you as well as for Dr. Noria, both of you all, that how do we get this into clinical practice, because that is where there's about 15-20 of us over here discussing this and another 100 people who are listening to us or more, but then how are we going to get it across the board into the clinical practice?
Very, very, very important, very practical, very good question, Amal. I'll give my views very short, and then we'll have Noria to tell us what he thinks. Two things. We need to get all the users to buy into this concept. And that's what you're asking, how do we make them buy into this concept? First thing is for patients. No patient wants to have a gastroscopy. It's an unpleasant procedure. You don't want to have it, especially if you have to pay for the procedure. So if you are paying for a very unpleasant procedure, it hurts. So what we need to do is inform every single patient having gastroscopy that if your stomach is full of food, mucus, or anything else, I'm afraid we'll have to repeat your gastroscopy. So you'll have to go through this unpleasantness twice, and there's a very strong chance the doctor will miss an early cancer. You will then present with a cancer later on, and it will be a wasted opportunity. And if you are repeating it, you have the discomfort of having it again. It screws up another 24 hours of your life because you get sedation and you can't drive and you can't do other things, and you have to pay twice. This will put a fear into the patient. They will listen to you, they will pay attention to you, and they will take care that they will fast adequately, and they will listen to whatever you tell them. Second thing, for us, for doctors to push this harder, I think we need, when I did the randomized trial in UK, I tell you, I didn't start about, my thought was not about repeating what I did in Japan. My thought was to do a national level study where I can go for a hard endpoint to say, randomize the patients into N-acetylcysteine plus simethicone versus conventional practice, and we will show an improvement in early neoplasia detection in upper GI tract. But the numbers needed were big, and it was very difficult to country to buy in because this was still a DIY solution. It had to be made, and there were a lot of barriers from pharmacy, from national society, from lots of people. So I had to put my ambitious idea on the shelf and go for the same thing. Now, with all of us here, I would propose that we should go for an ambitious idea, get some funding, get a sponsor, go for a hard endpoint trial where we can randomize patients into conventional practice versus the drink and go for neoplasia detection. Doesn't matter, squamous, Barrett's, gastric, whatever, neoplasia detection. And if we show that, Amol, every clinician will pay attention to it. This question will be dead forever. That's my point of view.
Wonderful, because I agree with you. I think the main barrier to accepting this technology and this practice is probably more from the physicians rather than from the patients, because patients don't know. Meaning most patients undergo a gastroscopy maybe once or twice in their lives. Some of them more when they are on screening, but by that time they already know the practice. But when they come in for the first time, that's the time they don't know, and we need to tell them the right practice policy, how it needs to be done. Any further comments from Dr. Noria? Would you want to add something?
So I cannot say such fancy words, but I was also involved in a committee member for Japanese guidelines. So at that time, I aware that usually, academic physician always attend congress or something, so they know many information, but it's only part of the physician practitioner, and on the basis there's many practitioner but we have to change such practice, otherwise all healthcare system does not change. So at that time guideline is very useful, so every practitioner can follow, and also in the past usually guideline is really evidence-based, but recently we are more practical, so committee member digest some evidences and then we can adapt such kind of practice into their own society. So if we can make such kind of very practical guideline, I think it's good to distribute practice and the knowledge to all society. That is my comment. Maybe India also have your own guideline or suggestion by yourself.
Right. Thank you so much. Meaning that's really encouraging. Now, Pradeep, the other question which I wanted to, this thing you mentioned about the distal esophagus, but what about the rest of the esophagus, particularly the proximal esophagus? Do you think it makes an effect anywhere, there as well, or is it mainly for the stomach and distal esophagus?
Well, we did not, in the West, we are so focused about Barrett's because the bulk of our patients have. So that was my vision. And that's where I went for, because I want to get this integrated into good practice for Barrett surveillance. But practically speaking, if patient has had a drink, and as soon as you start a gastroscopy, if you use a water jet, once you go past the upper esophageal sphincter and you start firing your water jet or put a little bit of flush with simethicone in the proximal esophagus, this will all drain downwards. Because N-acetylcysteine is sitting there, the mucus will get digested easily. It'll be very easy to suck and clear. So nobody's proven that it improves, but practically speaking, I think it will make a difference by combining it with some flushes.
Right. Thank you. That's true. Now, the other question, other point which I wanted to make is, when you're scheduling these patients for procedures, so do you have a dedicated person who gives the patient this drink in the waiting room or the waiting lounge? How do you schedule this 20 minutes before? Now that sometimes does get challenging because some procedures take a longer time, some patients take longer time to recover from sedation. And the other question which I had is, now in India, although a lot of our centers, we have started performing procedures definitely under sedation, but still, I think as you rightly mentioned, it is not common practice. A large number of places and EGDs are done without sedation, and apart from the drink, the other important variable which is important is optimal distension of the stomach, as Dr. Noria as well as you, both of you all mentioned. And unless the patient is really a little bit quiet, that distension can never be achieved. So would you recommend sedation as standard practice for all EGDs? And I want both your answers, Dr. Noria and Pradeep both, because there are differences. And also, how do you schedule these patients so that they get that drink 20 minutes before, not early, not too early, not too late?
I can go first very quickly. So in order to address the idea of the drink, I think in a study, we were very practical about the drink, anywhere between 5 to 30 minutes, we said. And our standard practice is 10 minutes, not 30 minutes. And it works very well. So the way it works is when the patient is called from the recovery to the endoscopy suite, at that point, patient takes a drink. By the time patient comes into your room, lies down, you give sedation, you check the pulse and blood pressure. Before you start, that's 10 minutes.
Right.
So practically it works very well. Just take the drink before you head into the endoscopy suite, and the drink would have worked its magic by the time the endoscope goes in. So that's how we work. Second thing about sedation, in our practice for all patients undergoing Barrett surveillance, we strongly encourage them and persuade them to have sedation because we need a longer time to evaluate the Barrett's and use all the technologies and take all the biopsies. And if the patient is struggling, it's not possible, so you don't do a justice. So we do that. We want to push it to everyone, but there are logistical challenges because giving sedation to everyone needs a bigger recovery space. It slows your turnaround rate, and that creates a problem. So you have to balance that against the best quality endoscopy. But my view is practical that if you know a high-risk patient, then always persuade them to have sedation. In other patients, if you've done a throat spray endoscopy, and if he's struggling and if you feel you haven't done justice to your procedure, don't hesitate in rescheduling the patient. Say you need to come back and have it under sedation. That's the way I think.
Thank you. And Dr. Noria, any comments on that?
Probably the same to Pradeep. So we also give the Simeticon and the Pronase 5 minutes before the procedure. So in this presentation, I knew that 20 minutes before is better than less than 20 minutes. But maybe we will improve. But and for sedation, in the past, Japan is the same. Maybe more than 90% is unsedated. Probably when Pradeep visited National Cancer Center, most of the Japanese patient was unsedated. But currently, now we moved to new building. We have a large recovery space. So 70-80% was sedated. So it's a bit, according to society or hardware sort of things. So for quality and the comfortness, sedated procedure is much better for me.
Definitely. I think, and COVID has made things a little bit more easier because I think during COVID, all of us started doing procedures under sedation. And that was one of the mandated things. And probably even after COVID, if we can continue that practice for at least 70 to 80% of our patients, I think that will be a great thing. Because you have a question here, please.
Dr. Amol, my question is, can we select the patient who requires the sedation? Is there any score, or can we check for the gag reflex? So is there any maneuver or the score where we can select this patient seems to be more anxious, he will require more sedation? So
probably I don't know of a score, but I think in your prior initial consultation and conversation with the patient, most often I think we will come to know the patients who are really very finicky and they're really going to be very anxious, and probably we can preemptively suggest sedation more strongly to them rather than to the others who are very casual about it. That would be my approach. Maybe I don't know about the rest. We do surprises sometimes. Yeah, when they get on the table, they are absolutely fine, and then suddenly once they are on the table, they panic, and then you've got trouble at hand. So that can happen.
I agree. I don't think there is any way of making that judgment call, but I would say, guys, I've had gastroscopy done twice. I know this is the most unpleasant procedure. Colonoscopy is a lot more pleasant than gastroscopy. So I think you should start with that baseline that this is unpleasant. Patient is going to retch, is not going to tolerate. So your baseline should be everyone should be sedated. But if they can't be sedated, then there has to be good reason why not. The only people I found who tolerate very well are those who do a lot of meditation. And in India, I'm sure lots of people are doing yoga and meditation. So if they can meditate while you do the procedure, you have no need for sedation.
Right.
And we
I-
found that, yeah, Dr. Mel, yeah, and we found that initial 1 or 2 minutes are more difficult. As the procedure goes longer, the patient becomes more calm actually. Initial 1 minute is, yeah.
What the most important thing is the post-cricoid sensation, that foreign body sensation in the post-cricoid area, which does not go away with your throat spray. And the patient is not used to that sensation. So until the patient gets used to that sensation, the patient is going to retch, they're going to be very apprehensive. Once they get used to it, and see, many people do get a feeling of getting choked, which is not true actually, but then they do get that feeling, and until they get used to the fact that they are not going to be choking and they're going to be able to breathe, you know that conflict remains. So that happens. Anyway, I think we are diverting from the main topic of mucosal cleansing to sedation and other things. So maybe we can continue with the next session. It was really enjoyable. Thank you, Pradeep, for your talk. And over to Dr. Ubal for the next session, please.